first off, really, I want to thank Peter and Verena for really bringing the MDMA research here to Switzerland. And it's great to be back in Geneva. I was first here in 1985 to lobby the WHO when they were thinking about the international criminalization of MDMA. We had sort of slowed down the DEA. They started in '84 to criminalize, and then we realized they were coming here to Switzerland to try to criminalize MDMA internationally and then say we had to follow suit. So it was really through the Assistant Secretary General of the UN that I had worked with, who also introduced me to Vanya Palmers back in '83, that set up this meeting here in Geneva in '85. And that really, in some ways, set the stage for the Swiss work from '88 to '93 with LSD and psilocybin, until it got shut down. So before I really start my slides, I just wanted to comment on some of the ideas, particularly from yesterday. There was one person that asked a question about, do we really need MDMA? Plant medicines are really safer. He was suspicious of synthetics, and is there some preference in a way to natural medicines and synthetics? And then Abigail did a really important discussion about the adverse events, but there was one that she had missed, a very serious one, but it's extremely rare. So during the Psychedelic Science Conference that we had in June in Denver, we had 12,400 people, and it was just absolutely amazing. And during the middle of it, I heard this story that there was, what had just happened was someone had taken psilocybin at a festival, had had a difficult experience, and had gone back to his tent, and this was America, he had a gun there, and in his difficult experience, he got the gun, and then he killed 2 people while he was in the midst of a really difficult psilocybin experience. And so the lessons that I drew from that is that, first off, this was happening when the media was focusing on what was going on in the conference, on what was going on about the legal research. And so in the 60s or 70s or 80s, this kind of horror story of somebody that has a difficult experience with psilocybin and goes out and kills people, that would have been the news. This did appear in the news, but it didn't really get widespread. It was more about the therapeutic use, the conference, and the hope story rather than the fear story. So I think that's a good example of how it is that we are making progress. So much of the stories about psychedelics now are about the healings, about the potential, and yet we cannot avoid the fact that some people get completely destabilized by more of the classic psychedelics, and then if they're not properly supervised, they can go out and commit violence, either commit suicide or kill other people. So I think it's also a commentary on plant medicines, that this can happen with plant medicines. They're not completely safe. People have this romantic idea that something, if it's from nature, it's okay, and if it's from the lab, it's not so good. So what we see in the US is all of these drug policy reform initiatives of plant medicines, natural plant medicines, and they're passing. They just passed in Colorado. There'll be another one on the ballot in November in Massachusetts. But when you add MDMA or LSD, all of a sudden, not enough people will vote for it because they're synthetics. So there is this kind of idea that if it's plants, it's nature, it's good. So I really think there's no difference between the molecules if it comes from a plant or if it comes from the lab. And that I think it's just kind of a simplistic way of thinking. But I do think that the cautions that we need to be aware of are that there are adverse events, and sometimes people are really destabilized. And so that cannot remain to be the dominant story. That's the importance of the research. So now I just want to start my slides. So MAPS I started in '86. I started a nonprofit before that in '84 to try to sue the DEA to keep MDMA legal. We eventually won that lawsuit, but the DEA ignored the recommendation and kept MDMA illegal. And it was clear then the only way forward was through the FDA. So Alex Gray, who is a psychedelic artist, this is his interpretation of the MAPS logo. And I'm sharing this to indicate that the foreground is the hands, the background is the psychedelic imagery. And what this really means is that it's therapy. It's about the therapy, it's about the humans helping humans, and the psychedelics are a facilitator of the therapy, but they are not independently the active therapeutic agent by themselves. And that's what we chose to illustrate in our logo. So I think that's something that as things get more pharmaceuticalized, as we see with ketamine, S-ketamine and Spravato, it was approved without therapy. I think most of the better ketamine clinics are combining ketamine with therapy, but we have to really beware as we go forward about sort of the traditional pharmaceutical ways that think the drug is the thing and they ignore the relationship, or in our cases, they'll ignore the therapy. So this again is just saying the therapy is the prominent point. This is just a pretty picture of a crystal of MDMA. So I want to say a sentence about why. So since we're here in Switzerland, this is one of the most important quotes for me from Carl Jung. This was from 1959 from an interview that he did. It's up on the internet. Face to Face was the TV show. But what he said was, we need more psychology. We need more understanding of human nature, because the only real danger that exists is man himself. He is the great danger, and we are pitifully unaware of it. We know nothing of man, far too little. His psyche should be studied because we are the origin of all coming evil. Now, this was someone who had observed World War II. This was a few years before he died. And so I think when we talk about all the crises that humanity is facing, that the crisis of consciousness is the one that's the most widespread, and it could have the most implications in a positive way if we are able to shift our consciousness in a more spiritual way, in a more unitive, mystical manner, practical but mystical. And I think this idea of natural disasters, those are not evil. There's a lot of things that can hurt us, but they're not evil, but we are the source of all coming evil. And so I think that's why we need psychedelics and depth psychology and learning about psychotherapy. So in a big picture, where are we right now with MDMA-assisted therapy after 37 years and a half? We have 2 successful phase 3 studies. We published both of them in Nature Medicine. We're gathering all the data, and we anticipate submitting it to the FDA the first couple weeks in December of this year. And because it's a breakthrough therapy, we have an accelerated review process of expedited review of 6 months. And so once FDA asks questions, the timetable, the clock stops, but we've got 100 plus people ready to answer any of their questions as fast as we can. And so we're hoping that by the middle of 2024, there's a good chance that we'll have FDA approval. And beyond that, I would say a year and a half to 2 years afterwards should come psilocybin. And then beyond that should be coming 5-MeO-DMT and possibly ibogaine and other things as well. Thank you. One of the questions yesterday was, if you could go back to the 60s, what would you change? And I've thought about that a bunch. And what I think I would have changed is if Timothy Leary and Ram Dass got kicked out of Harvard in '63. But it was kind of willful on their parts. Leary didn't go to classes. He could have stayed if he wanted to, but he was attracted more to the larger political struggle. But I think if they would have stayed at Harvard and kept the research in the institution, it might have been a whole different way that it turned out. But I think Timothy Leary has done a lot of really good things as well, particularly urging people to think for themselves, to question authority. And so I invited him at the first big conference for MAPS in 1990. And after his talk, I went up to him and I said, Tim, what advice do you have for us, for those of us trying to work with the government? You've had all this experience. What is your advice for those of us that are really trying to work through FDA and work through the government? And his immediate response was, fuck the government. He said, I am so far past asking for permission, but I'm glad you're doing it. And that's when he held up my hand. So I felt like this was the passing of the baton from the 60s to the 90s and beyond. Now, we've heard a lot about mechanisms of action and things like that a bit from Michael Midover's talk yesterday. But one thing I want to add here is that what we know from the research that was done in the 60s with LSD and the modern research over the last 20 plus years with psilocybin and with classic psychedelics is that there's a correlation between the depth of the mystical experience and therapeutic outcomes. This is for people who are depressed, people who are addicted, people who are anxious about dying. In all the research with the classic psychedelics, this has been a pretty solid finding. The depth of the mystical experience leads to deeper therapeutic outcomes, or if not leads to, is associated with. So we use the same mystical experience questionnaire that's used in the classic psychedelic research. People don't score quite as high as they do on MDMA as they do with the classic psychedelics, but they do score pretty high, high enough for us to have run a correlation with 2 of our different phase 2 studies. And what we show is that there is no correlation between mystical experiences and recovery from PTSD. So it's the one fundamental difference that we can say between the therapeutic approach with classic psychedelics and the therapeutic approach with MDMA. You do not need a mystical experience to reintegrate, split off parts of yourself from trauma or to process difficult traumatic memories. You can have a spiritual experience and it can have other benefits, but it's not a key part of the process of therapy to heal PTSD. And as a result, that leads to our therapeutic approach, which Michael talked about, self-directed, inner-directed, that we're not trying, we don't have an agenda to try to move it into people letting go into a mystical experience. If that happens, that's good, but so I think this is just something in terms of psychological mechanisms of action to keep in mind, that to move past lifetime experiences in your life, in your biography of trauma, it's not necessary to have a mystical experience. And in fact, that can sometimes, we've heard about spiritual bypass, where you bypass these experiences. Now, about the mystical experience, Vanya talked about Brother David. So I am proud to say that I was the one that gave Brother David and Vanya their first MDMA. and several others as well. And so what Brother David said, and this was something that he tried it when MDMA was still legal, half dose, again, not microdose, but half dose in the monastery, and was able to feel that it quieted his mind and helped him to have a deeper meditation, and then he could learn from that without the drug. And he said a monk spends his whole life cultivating the same awakened attitude that MDMA gives you. And so this was part of our political strategy, again, of having different kind of voices that would speak about MDMA, not just hippies, but monks and rabbis and others. So there is this possibility of a mystical experience of different kinds with MDMA at different doses. And Brother David also was just, as we heard, this idea of gratitude. One of the most important books I've read was Gratitude is the Heart of Prayer. And he makes it that a mystical experience is not something abstract, that you could have it multiple times during a single day when you just be grateful for the sun or grateful for things. So this is the background now to our phase 3 studies. And so you need to do 2 phase 3 studies for the FDA, for regulatory agencies. The first one is called pivotal, and then the second one is confirmatory. Now, the way the FDA works is you need 2 successful studies, but you can do 10 studies and have 8 of them fail. As long as you get 2 that are successful, that's enough to move to getting it approved. And a lot of the other drugs that have been used for mental illnesses, they have multiple different failed studies. And pharma in the past would hide those. You'd never learn about the failed studies. Now you go to clinicaltrials.gov, a website, and you have to list your studies so that the failed studies cannot just disappear. But you just really need 2. And so we've published our first phase 3 study in May of 2021 in Nature Medicine. And I won't go over the results. I'll tell you more of the results of the MAP2, the second phase 3 study. But I will say that at the end of each year, the journal Science, which Science and Nature are the 2 most important scientific journals in the world, Science publishes a list of the top 10 scientific breakthroughs in the world for the prior year. And so for 2021, Science picked our study as one of the top 10 scientific breakthroughs of the world. And it was surprising in a couple ways. First off, I don't think it was just for our study. It's the fact that we are the first one in psychedelic-assisted therapy to get to phase 3, and it was such a successful study. So the award is really to us, but it's really to the whole field. And the other thing that made this so satisfying for those of us that had a long-term view is that 20 years before, Science had published a paper by researchers at Johns Hopkins, funded by the National Institute on Drug Abuse, that claimed that MDMA could hurt dopamine and could cause Parkinson's. And the editor of Science in a press release said that MDMA is like taking MDMA is like playing Russian roulette with your brain. It was super loaded. And in this study, you know, Michael, when he spoke yesterday, talked about the length of time between when we got FDA approval and when we were able to finally get the ethics committee and the DEA approval. It took about 3 years for us to really start the first MDMA PTSD study in the US. And it was in part because the Science had published this previous paper that seemed fishy to us for a bunch of reasons. And eventually what happened is we challenged them. Quietly, they spent a year trying to replicate the results, and then they finally admitted in public, while they had previously defended it for this entire year, that they had made a fundamental mistake, that somehow or other they had administered methamphetamine instead of MDMA to these primates. And that methamphetamine is way stronger than MDMA. So what they're doing is they're administering methamphetamine in MDMA doses to these primates. They killed a bunch of them, and they ignored that. But in any case, for Science to have published that, it was really an arm of the drug war. This Science study was particularly flawed. So 20 years later, for them to say that our study was one of the top 10 scientific breakthroughs of the world was particularly satisfying. And it's, again, another sign of the cultural shift. And then we've done a study. The key part is, can you generate short-term results? That's important. But the key part, particularly for insurance coverage, is it durable? And so we've just done a long-term observational follow-up, some a minimum of 6 months, but some to a year or more, and we demonstrated that the results have been durable. We've done other longer-term follow-up studies for phase 2. But September 14th of this year, we published the results of our second phase 3 study. And we're delighted. The New York Times had a whole-page article about it. And I've got it framed on my wall. MDMA therapy inches closer to approval. So the first thing to share about this is that the first study that we did was severe PTSD. And I had the mistaken idea that because we do work with veterans, even though most of the people that have PTSD are women, and it's mostly from sexual abuse or domestic violence or things like that, the media gives most attention to the veterans. And so I had just assumed, because 40% of the veterans in America are of color, that we would have a fair representation of minority groups in our study, and we had none. We had absolutely none. And that was just surprising. I didn't realize the depth of distrust that African Americans have about the system, the medical system in America, the racism in America. And so what that made us realize is we had to train more therapists of color to get more patients of color. And we had to really try harder to get a diverse group of patients in our second phase 3 study. So we were able to do that, and we had 26.9% Hispanic Latino, 33% other than white. And so we did have a fair amount of African Americans as well. So we're really proud that we were able to get more of a diverse group in our second phase 3 study. And we were able to do that, again, through giving scholarships and trying to train therapists of color. And as we think about globalizing, we're going to have to really think about therapists from all the different countries and having them learn how to do this work and then train other people. So the first study was so successful that we met the criteria for applying to the FDA for reviewing one phase 3 study instead of 2. But the FDA rejected our proposal, even though we met the criteria, and said that they were somewhat persuaded about efficacy, but they really needed to do the second phase 3 study about safety. So what were the results of our second phase 3 study? Now, this was moderate to severe. The first one was severe. The reason that we started with severe is we have to do, again, the most difficult cases, but we didn't want to be limited if the second study was just severe, that then they might say it's only for severe PTSD. So the second one was moderate to severe. And it's 42 hours of therapy. It's with 2 therapists, often male, female, but not always. And the goal for us, the operational philosophy was, how do we maximize therapeutic outcomes? It's not how do we get good enough at a least cost so that it will meet economics to be covered by national health insurance. Those are critical questions. But for us, the question was, what is the best we can do? How can we help the patients the most? And so we have a system that is 42 hours of therapy by 2 people. First person needs a license to do therapy. The second person can be an assistant, doesn't need to do a license. So in the second study, we had 47.6% of the moderate to severe people. There were about 3/4 were severe, 1/4 for moderate. But at the 2-month follow-up, after 3 MDMA sessions or experimental sessions, in this case with the inactive placebo, almost half of them no longer qualified for a diagnosis of PTSD. It's incredible. In our first study, it was 32% in the control group. So I think there's a couple reasons to explain why it's better. I think part of it is that the therapists who work with psychedelics, who work with MDMA, they feel that they become better therapists even without the MDMA. They're more able to tolerate different emotions. They know how to move people through letting things go instead of getting nervous and trying to shut it down. The other part, I think, is that we have these 8-hour sessions. So even if you don't have MDMA, you've got music, you've got therapists, you're all set to do deep work, and you're not guided or forced or directed to talk about this one index trauma. You have kind of an open space to come around however you want to addressing these emotions. And the trauma does come up at different times. So we're able, I think, to show that the therapy that we've used, independent of MDMA, for people who have chronic PTSD, that the therapy itself is comparable or even potentially better than some of the other therapies for PTSD for a bunch of different reasons. But when you add MDMA, it gets up to 71.2% of the people that no longer have PTSD. So these are pretty remarkable. This was 0.0004 statistical significance, 1 in 2,500 chance that it was random. The first study was 1 in 10,000, 0.0001. And none of this efficacy data would be really enough without looking at the safety. It's really important to understand the risk-benefit balance. And so it's kind of a bit hard to read, but there are a bunch of acute, transient, non-serious side effects that are all more involved in the people that get the MDMA than the people that don't. Muscle tightness, sweating, things like that, feeling cold. There's different these side effects. But we did not have any serious adverse events in this study, either in the MDMA group or in the placebo group. And these adverse events are pretty similar to the adverse events in the first phase 3 study. But in the first phase 3 study, we did have one woman try to kill herself twice, and we had another woman that had such severe suicidal ideation that she checked herself into a hospital not to kill herself. Both of these women were in the placebo group. And so we didn't have anything like that in either of these studies in the MDMA group. Now, one way to look at how the therapy is tolerated is to look at the dropout rates. And so this is particularly remarkable. So the Veterans Administration last year published a study. It took them about 6 years to do this study, 914 veterans. And what they were doing was they were comparing prolonged exposure, which is one of the main therapies for PTSD, used in the VA, with cognitive processing therapy, which is another of the main therapies used inside the VA. And what they showed was that almost half of the people, well, 55.8% in prolonged exposure, 46.6% in cognitive processing therapy, half the people dropped out of the study because it was so difficult to confront your trauma in this way where you're constantly directed to it without any fear reduction from MDMA or anything. These therapies are difficult and they're very re-traumatizing for some people. So their dropout rates were around 50%. Half the people dropped out. So the dropout rate that we had was 1.9% in the MDMA group. incredible. And then the therapy with placebo, 15.7%. So part of the reason that we, I think, have a lower dropout rate in our therapy group is, again, that we're not sort of forcing people to confront their trauma. They confront it when they're ready. If they're starting to feel overwhelmed, we encourage them to be overwhelmed and to let it go. But if they don't want to, they can back off and do other things. The other part of it is that we have a crossover, meaning that everybody who is in the placebo group, after the whole study is over and we uncover the blind, they can go through the study again and this time receive MDMA. So those are the things that I think contribute to the dropout rate being low in the therapy. But this 1.9% dropout rate is astonishing, I think, for demonstrating that the fear reduction parts of MDMA help people deal with these overwhelming emotions and stay in therapy. And the Veterans Administration has realized this. The Secretary of the VA and the Undersecretary of the VA recently met with Rachel Yehuda, as a researcher we work with at the Bronx VA, and they interviewed an MDMA patient, and they were very impressed. And then they did a podcast, the Undersecretary of the VA, with another of our patients and circulated it to everybody in the VA. So we're really starting to see major progress inside the Veterans Administration. And I think that these two successful phase 3 studies are giving us a lot of hope that we can demonstrate in rigorous controlled context as predetermined by the FDA, also by Israeli Ministry of Health and Health Canada, that even inside these kind of normal or sort of rigorous constraints, we can still get great results. But we have our treatment manual, we have our method, and I think for political reasons and also for humility reasons, there may be other ways of therapy that work as well or better than our particular therapeutic approach. But also what we want to do is avoid backlash from all the therapists who spent their careers developing non-drug psychotherapies of a different kind than MDMA. And so what we're trying to do, and what we are succeeding in doing, is supporting studies to blend MDMA with other therapeutic approaches. And so we're really wanting to see therapists can bring their particular skills to the research that they're doing. And so one of the ones that's most important that I'm very excited about is this MDMA-assisted cognitive behavioral conjoint therapy. It was 1995 that I first tried to offer money to the VA and therapists saying, we want you to do MDMA research. And this was, again, mostly Vietnam vets with PTSD. And it kept getting rejected and rejected and rejected by political people. The psychiatrists and therapists that wanted to work with us that see the patient need were there, but the political people were squashing it. It wasn't until 2014 that we got the first permission to work with VA therapists, but they had to work outside the VA. We had to pay for it. The VA wasn't going to refer any patients. But cognitive behavioral conjoint therapy is a way where you leverage the relationship that people have with a significant other. And so you bring two people into the therapy, the veteran with PTSD and their partner. And it's quite effective because a lot of times the patient, the designated patient, gets all the attention. Their spouse or their partner is suffering in different ways and they don't get as much attention, and yet they need to be supported in trying to help the vet and work themselves through it. So it's not exactly couples therapy, but there are measures of the relationship, but it's a study where the primary outcome measure is the PTSD of the veteran. And so we were able to start this, and Michael and Annie Midhofer worked with Candace and her partner, Ann Wagner, her protege, Ann Wagner, on this particular study, did 6 dyads, and the results were better than anything they've gotten before, both in reduction of PTSD and in strength of the relationship. So this is something that I think has a really important maneuver to go forward, because also once you start treating people's families, then you're starting to broaden the web of support. And so Anne is now doing this study combining MDMA with cognitive processing therapy. What seems to be happening, and we'll see more when she's done, is that the techniques of cognitive processing therapy, and as before in cognitive behavioral conjoint therapy, the techniques tend to be used in the preparation and the integration, and the MDMA session itself looks more and more like our inner-directed, self-directed therapy. So we are supporting studies to blend MDMA with prolonged exposure. Barbara Rothbaum at Emory is one, and Edna Foa developed prolonged exposure. It took a while to get her involved. She thought that MDMA was dynamite in the brain. 2009, Michael and I met her, and she was like, oh, this MDMA is terrible, don't ever have anything to do with it. Barbara wanted to work with us. Edna said, don't. Edna said that we should just skip MDMA and just go to VR. And there was a guy named Skip Rizzo at this conference in Jerusalem, and I went to Skip and I said, Edna thinks MDMA is terrible and it's dynamite in your brain. You know, she says we should do something with VR, and you're doing VR, what do you think? And he just laughed and he said, if you have MDMA, you don't need VR. But actually we're talking to him now after all these years about you could do VR patients and you could imagine VR being helpful in the training of therapists. But I think VR gets people into the track of what is programmed into the VR, but patients may need to pivot to other traumas, and I think you don't get that capacity when you keep them. Yeah. Oh, VR is virtual reality. So it's like the goggles that are outside there. So yeah, it's a way to kind of be in a different environment. And there is some work that they're doing with VR for PTSD. Now, we're also, Ben Sessa has done really good work in England with people with alcohol use disorder with MDMA. And what he found was that most of the people were running away from trauma. If you help them process the trauma, then they don't need to run away in alcohol. And this would be true, I think, for other substance problems. This is now a terrific project, also, again, moving from an individual to a couple, where this was Sunstone Therapies outside of Baltimore. And this is MDMA-assisted therapy for adjustment disorder in dyads of patients with cancer and a concerned significant other. So again, they're giving MDMA both to the cancer patient and to their partner, and these results were also really remarkable. But from a political point of view, it's really what can we do inside the VA that sends a message to our society that this is acceptable. And so it took until October 12, 2021, from 1995, 26 years before the first veteran received MDMA for PTSD inside the VA by VA therapists, and that was at the Loma Linda VA. Shortly after that, Rachel Yehuda was able to administer MDMA to therapists. Now, Rachel has done really important work with Holocaust survivors and their children and has identified epigenetic mechanisms by which multi-generational trauma can be passed down, either through the mother or the father. And so in this study that she was doing 2 sessions versus 3 sessions, there's also epigenetic measures. So we will be trying to investigate whether we can both help people deal with the traumas that they've experienced, but also make it so that they don't pass this on to the next generations. Now, group therapy is going to be one of the most important ways to try to see if we can make this scale better, if we can reduce the costs. It's going to be, I personally don't know if group therapy will be as effective as individual therapy. I tend to think not. I think that telling your story after you have these kind of imaginative, metaphorical kind of experiences where you're writing your own story and feeling different, then telling it to the therapist, I think is part of this rewiring your brain, and there won't be as much of that in group therapy. But on the other hand, the group therapy can reinforce each other in the integration process. So potentially this could be as good, better, or not quite as good, we don't know. But this is about to start. So the first people will get enrolled in January of next year in this group therapy study. But people are going to get 2 MDMA sessions. The first one is going to be individual, and then the second one is going to be in a group. So we're approaching this very cautiously. We're a little bit concerned about bringing people who are severely traumatized into a group where they've never done MDMA before and then have to navigate both the social context of being with the other people and also their own inner experience. So everybody in our group therapy study is going to get an individual session first and then a group session later. So this is now at the Palo Alto, the Stanford VA. This is going to be a direct comparison study of MDMA versus cognitive processing therapy. For FDA, you don't need to do these comparison studies, but this is now going to be an attempt to directly compare. This will be really helpful for the VA to, if to use this data to figure out about rolling out MDMA possibly inside the VA. We also use an inactive placebo. This is at the West LA VA. This is going to be MDMA therapy compared to therapy with an active placebo of D-amphetamine. Why I'm concerned about this is that a big part of my dissertation was about how to do double-blind studies. We know that psychedelics, if I were to give all of you here a pill and half had MDMA or half had nothing, I bet you would be pretty 100% on who got the MDMA and who got nothing. It might not be 100%. It could be 90, 95%. Sometimes people are confused. Sometimes people so want to have an MDMA experience that they will have it even if they got a placebo. But what we did in our efforts to try to see how to do a double-blind study was to use test 0, inactive placebo, 25 milligrams, 30 milligrams, 40, 50, 75, 100, 125, and 150. This is what took us 16 years to do all this stuff, the phase 2. But what we showed, I thought what we needed to do is find the dose of MDMA that was high enough to cause confusion, could it have been a full dose, but not so high that it would be so effective that there would be no way to tell a difference between the two groups. What we discovered instead was that the lower doses of MDMA actually made people uncomfortable. And even though they still showed reductions in PTSD symptoms, they didn't have as much reduction as the people that got therapy without any MDMA at all, inactive placebo. And so it's like turbulence in an airplane. When you're starting to take off, there's a bunch of shaking, then you kind of get above the clouds, and then it's smooth sailing. So using D-amphetamine as a control here, my guess is that it may activate people without the fear reduction, similar to low-dose MDMA, and it may actually compromise the effect of the therapy. We won't know until the study is done. But anyway, this is inside the VA, they also wanted to see an active comparator. The FDA said that after we showed them that it should be, you should make it harder on us to show a difference between the two groups. And if you can do therapy without MDMA, you should do that. What is the real difference? And so the FDA and EMA have both indicated that they would approve studies with inactive placebo. But anyway, this is going to be an active placebo. And then we're trying inside the VA to do now 2 of these cognitive behavioral conjoint therapy studies. The San Diego VA, they're just going to give MDMA to the veteran with PTSD, and in the Phoenix VA, they want to give MDMA to both members of the dyad. And so to give you a sense as to the timetable, this is a complicated slide, but this is just to say that we anticipate, as I said, first couple weeks in December, submitting all the data to the FDA. Then sometime around June, we hope that FDA approval will come. If that happens, then the DEA, the police, must reschedule. They have 90 days to do that. Then in the US, the states have to reschedule, automatically, we have to do something or other with the Board of Pharmacy or Board of Health or different things. And so we think by the end of 2024, near then, we should have MDMA-assisted therapy for PTSD be on the market as a prescription drug. And we're hopeful, based on our previous discussions with insurance companies, that it will also be covered by insurance. Whether it'll be sufficient, I mean, Peter, you're saying that the reimbursement in Switzerland for therapists is not really sufficient. That is the way it's also in the US, but hopefully we will negotiate as high a payment as we can to the therapists. Now, one of the things that they're called phase 4 studies. So after you get approval, there still can be requirements of things that you do while the drug is being marketed. One of the most important ones that we're being required to do is to study adolescents with PTSD. And this would be 13 to 17-year-olds. If we do get approval, it's 18 years or older. If this study works, then we're going to have to work, meaning this adolescent study, then we have to work with 7 to 12-year-olds. And we did hear a good talk about the kind of concerns about animal research, but one animal study was in octopuses. Michael mentioned it yesterday. Octopuses become more social when they're given MDMA. So I don't think any octopuses were harmed in this study. But it shows the pro-social aspects of MDMA are pre-verbal, evolutionarily conserved, and they should by a great hypothetical leap, work well in children as well, even if they don't have the capacity verbally to explain what's going on. So I'm very hopeful about these pediatric studies, and I also think that we need to treat people closer to the trauma instead of letting it festering over years and getting worse. And also, just from an economic point of view, from an insurance company's perspective, they look at quality adjusted life years as one of the metrics to see whether they'll pay for something. And so the economics are stronger for younger people because they have more years ahead of them to be in an improved state of mind. So I think that, and also once you start helping people's children, then the whole society is behind you. And if we look in America at one of the key turning points between the acceptance of medical marijuana, it was early work that was done, Sanjay Gupta on CNN and others, it was with CBD, not even THC, CBD for childhood epilepsy. Once it was helping people who had this, kids who had these seizures many, many times a day that nothing seemed to work for, but CBD would calm these seizures. That really changed the dynamic in America. So once we start working with people's kids and start helping them, then I think we're fully integrated in society. The other issue that we have to do is we require people to taper off their SSRIs to be in the study. And Matthias Lichty and I had a discussion about this yesterday. There's some evidence to suggest that anecdotal evidence, that if you work with people on an SSRI, we know that ketamine you can give to people on top of all their other medicines, but the SSRIs blunt the effects of MDMA and to some extent psilocybin. So the question is, can you give higher doses of MDMA to overwhelm the blunting effects of the SSRIs, but not cause serotonin syndrome? Because there's a fair amount of people that we've encountered in the Veterans Administration and others that don't want to taper off their SSRIs. So if we could manage to treat people while they're still on their SSRIs, much better to have them taper, but if they're not willing to do that, if we can help them reduce their symptoms to some extent, then the fear of tapering will be reduced. So anyway, we need to do this kind of a study to determine whether MDMA can be used in people on SSRIs. We've partnered with Compass Pathways. This is the group that's making psilocybin into a medicine for treatment-resistant disorder, treatment-resistant depression. And we lobbied the American Medical Association because one of the big questions, and we heard this also about insurance coverage for one or two, I think Joost was saying this, that how do we get coverage for 8-hour sessions? So we managed to persuade the AMA that psychedelic therapy was a different kind of a situation than traditional 50-minute or 55-minute therapy sessions, and that we need a billing code for long therapy sessions. And so the AMA agreed, and it's going to become active as of January 1. So this is a real key development, and I think what this demonstrates to me is that if we get really great outcomes, we don't need to squeeze what we're doing into the traditional paradigm. The traditional paradigm will expand to accommodate these new psychedelic-assisted therapies. Now, we had a formal dispute. Once it's approved, who's going to be able to provide this, and also what will their training be? So we have a protocol that the FDA gave us permission for. It was to give MDMA to therapists as part of their training. We had 125 people go through that, and we surveyed 79 of them, and they were very strong in how important this was to them to be more effective as therapists and also personally help them. And so we tried to get another protocol simpler through the FDA. They said, absolutely not, we'll never approve it with you. The leadership of the Division of Psychiatry changed. How many minutes is that? 10, okay, great. So the leadership changed and they refused to give us permission. And we gave them all this data about our phase 2, our phase 3 studies. Here's the sites that had MD PhDs in the team. Here's the sites that didn't, no difference in efficacy. They also wanted us to have a doctor on site instead of on call. These are both poison pills for the entire industry. If you had to have a doctor on site in every clinic where they're really basically sitting doing nothing, it's too expensive. And MD PhDs, it's a complete misunderstanding because first off, it's more expensive, but secondly, a lot of psychiatrists don't know anything about therapy. They're trained in psychopharmacology, but they don't really, and clinical psych PhDs are also trained in measurements, a lot of things. They're not necessarily in any way better therapists than people that are licensed therapy, but from the FDA's point of view, oh, it looked like they were being careful, you know, MD, PhDs, and they couldn't impose it on us in phase 3 because we had an agreement called the Special Protocol Assessment where we agreed on all the dimensions of what phase 3 would be like. But for new things, they tried to impose it on us, and they did impose this successfully on Compass and Usona, the two groups working with psilocybin. So we objected, and they didn't listen to us, and we took that as a symbol that really they had no arguments, but the lower level bureaucrats didn't want to take responsibility for making a decision like this. So we hired really excellent kind of lawyer scientist types. We spent $250,000 on lawyers, and we won completely. And so MD, PhD is out the window, doctor on site is out the window, and they gave us permission for another protocol to give MDMA to therapists. Not only did it help us, but it also helped the psilocybin. So now the psilocybin people don't need MD, PhDs either. So what are our ambitious goals? We want to train 25,000 therapists by the end of this decade. And by 2032, we want to treat about 1.5 million PTSD patients in America. That might sound great, but actually there's 13 million PTSD patients in America. So what we're saying is in the next decade, we're hoping in our big dreams to treat 10% of the population of PTSD patients in America. Now, what this doesn't count is group therapy. So that may change the dynamic completely, but it just suggests that the scale of the need is so important, is so enormous, that we don't think of the people who are developing psilocybin or the people who are developing 5-MeO. They're not competitors. We are all working together to bring forward psychedelic-assisted medicine. It will be important one day to try to figure out, is this patient best for this drug or that drug? But really, it's we're all in it together, and it's about all the different psychedelics, and it's about empowering the therapist to be cross-trained. So the future psychedelic clinics will kind of be like this, where you'll be able to say, oh, I'm going to go to this one, and they'll figure out, they're trained in all these different drugs, and they will decide what comes first. Is it MDMA? Is it psilocybin? Now, I've talked just about MDMA. Briefly, I want to say that we're working with ibogaine. We've done these observational studies in New Zealand and in Mexico. For 1 year, we would test people in the addiction severity index at baseline before they'd go to these clinics, and then 1 month after for a year, and it was promising results. We're working with ICERS in Spain. We're a small funder of their study to work with helping people withdraw from methadone. And now in America, because last year we had over 100,000 people die from opiate overdoses, and there's just such an enormous scandal about pharmaceutical, particularly the Sackler family and Purdue Pharma that just massively pumped OxyContin, and other things, so that they've paid billions of dollars to different states. So Kentucky is getting something like $480 million, just this one state, in reparations in a way from pharma for the damage that was caused from all these overprescription of opiates and the dependence and death that came from that. And so the state of Kentucky is talking about $42 million for ibogaine research. It's not a done deal. I testified a couple weeks ago before a commission, but it's looking promising. So several groups and I are thinking about combining our forces to try to use public money and donor money to develop ibogaine, completely open science, with the goal of making it into a generic. And if we can do that without investor money, then we can make it into a generic immediately. So that's what we're thinking about trying to do. But the Kentucky money is only a matching grant. So if they do allocate $42 million, we have to find $42 million from elsewhere. And the Benefit Corp, the MAPS Public Benefit Corp, which is our pharmaceutical arm, separate from the nonprofit, is becoming a commercialization engine to work with all these thousands of therapists and to develop the infrastructure for patient access. And so with ibogaine or other drugs, we don't need to duplicate this commercialization engine. We just need to get it through the FDA, and then we could have license it off to this marketing engine that we're also building. Now, we are doing work with cannabis. we have a $12.9 million grant from the state of Michigan to do a cannabis PTSD study. Cannabis for PTSD is palliative. It's not that much different from SSRIs. It's the kind of thing that's a daily dose. It doesn't solve the problem. It just controls some of the symptoms. But there's, again, like a lot of people that don't want to taper off their SSRIs, there are a lot of people that don't want to do MDMA therapy at all, and they would like something that just controls their symptoms, but doesn't have the side effects of the SSRI. So there's loads of people, hundreds of thousands of people, potentially millions, using cannabis for PTSD. The problem we've got with the FDA is because they are also trying to limit the use of tobacco in the United States, is they're refusing to let us study people smoking marijuana. And they're also refusing to let us study people who vaporize the bud. And those are ingestions through the lungs. Those are the best way, the most rapid way to get feedback. So we are now working with the same lawyers. We're going to submit something in the next couple weeks to FDA with expert committee. So if that doesn't work, then we're going to be launching another lawsuit against the against the FDA for cannabis. All right, so beyond what I've just said, very touch on something is that you know all the conflict in the Middle East. There are Israelis and Palestinians, small groups of them, not the hardcore haters either, that are doing ayahuasca and MDMA together. Lior Roseman has done great work with ayahuasca. MAPS is developing a study to do MDMA. So it's like, how do you help people overcome their trauma, less stereotypes of other people, see the common humanity? Can psychedelics have a role to play in cultures and countries in conflict? We were just about 2 weeks ago to train Palestinian therapists, and the war broke out just a week before that. Next week, I'm going to Iceland. We're having a training of therapists in Iceland, and we've got 4 Lebanese therapists who are scheduled to come. And we have full funding and everything if we can move into Lebanon. Now we don't know if that's going to happen either. But again, this is sort of a long-term plan. How do we help people, not just their own therapy, but conflicts between groups? And the same is true for couples therapy. All right, so the new goal of this is toward a world, so you know, the vision was make MDMA into a medicine for 37.5 years. Now it's toward a world of net zero trauma by 2070. Bhutan has a measure of gross national happiness, gross national product, all these measures. We need to make one of gross national trauma. These are all kind of the domains of it that we made in 5 minutes while we were stoned. And we'll eventually have to operationalize this with a couple $1 million. But the goal for here will be, how do we prioritize global communities with the largest burden of trauma and the fewest resources for treatment? And to end with this, almost end with Carl Jung, he said the best political, social, and spiritual work we can do is to withdraw the projection of our shadow onto others. And I think that is really the challenge of the age. And if everything goes well, in 2070, we could have a psychedelic utopia, a spiritualized humanity, mass mental health. And I'm talking about the book The Island by Aldous Huxley. I'd really recommend anybody to read that. It's about an idyllic psychedelic society, but in the end of the book, it's destroyed by the oil companies. And if you've seen the movie Avatar, it's the same story. You know, this beautiful culture that's destroyed by the larger civilization. So that's why what we need to do is there are no private utopias in nuclear weaponry and global warming. We have to go to the heart of the system and reform from the inside out. And that is our mission, and I'm glad to see how much progress is being made in Switzerland as well. Thank you. Yeah, thank you.
Thank you so much.
Okay.
That's great.
Okay.
Give it up for Rick Doblin!
Hey, thank you. Thank you. Thank you. It's oh, yay! Thank you. Thank you. Well, wow. Well, thank you. Oh. Yay. Thank you. Thank you. I will share, though, that for all the benefits that psychedelics have given to me in my life, I've not even begun to pay it back to the world. So
That's nice.
yeah. Okay, so if there's time for questions.
Yeah, come on.
Oh, sorry.
Okay, 2 questions, but keep it short. He will also be back on the panel, so if you have any more questions, then we can probably also arrange it. Okay, yeah, you guys choose. In the back. Yes.
Hi, thank you, Rick, for a great presentation and inspirational work. You mentioned WHO in the beginning, and
Yes.
Are you planning on trying to get a critical review by the WHO started sometime soon now that you have phase 3 data to give them?
Yes, we would like to do that, so that once we submit the entire package to the FDA, then it will be something that will be easy for us to submit to other organizations like WHO. Whether they will accept that for a review, we don't know, but we definitely want to globalize in that way. Yeah.
Okay, so I wanted to ask how you view the United States as, like, since we don't have nationalized healthcare, we have a private system that's very different than a lot of other like global north countries with developed healthcare systems.
Yeah.
How do you view the US as like a front runner in psychedelic therapies with respect to like scaling it up around the world, since it's such a different place to practice medicine, to practice therapy?
Yeah. Well, one of the things that I didn't talk about is that we basically have a two-pronged strategy. Because in America there's a quarter to a third of people that don't have insurance, and more that have insurance but is underinsured, and won't get much coverage for psychedelic therapy. So how do we want to develop this in the US, and then also how does that help us with globalization? So we've had a 2 parallel track strategy, and this is something that I think is unique to us as a nonprofit that started a pharmaceutical company. The parallel track is drug development, obviously making these things through the FDA, but the other is drug legalization and drug policy reform, and training people in peer support, in harm reduction, in understanding the realms of the human unconscious, as Stan talked about, trying to embed that knowledge in the population so that we can address how do we provide access to people that don't have insurance. We will be able to provide what's called patient assistant funds, but if you see, you don't have it here, but in America we have all these ads on TV about pharmaceutical companies, and they always say, if you can't afford the drug, talk to us, we have programs to give it to people that can't afford it. For us, if we give people free MDMA, it does them no good if they can't afford the therapy. And we cannot give the MDMA to people either outside of therapy. The way we're going to try to negotiate with FDA, it's only administered under direct supervision of therapists. It's not going to be like Spravato where you can go ahead and send it to people on their own. So that I think the challenge is going to be for us to eventually get national health insurance, if we can ever do that in America, to try to get parity between mental health coverage and physical health. But I think it's not going to happen anytime soon for those things, so I think that's where the drug policy reform. The problem is for us is that, as I started out, people are scared of synthetics. And so all of these drug policy reform initiatives happening in America are happening with plant psychedelics, natural plant psychedelics, but not MDMA. So it's going to be a more difficult time. The other thing to say is because there's such a crisis in terms of opiate and fentanyl overdoses, that there's virtually no pressure now on underground psychedelic therapists or on, there's so many new psychedelic churches in America that are would not meet the US Supreme Court test for being a real, quote, religion, but there's no enforcement about that. So I think that's going to be how we do it in the US. How that helps us around the world is if we do have FDA approval, then it's going to be much easier for us to get EMA approval to MHRA in England. Because they've pulled out of Brexit, they don't have the resources that they had before when EMA was located in London. Now it's in Amsterdam. So that MHRA is talking about maybe they'll approve drugs after FDA approves them. We want to work in Ukraine also, so that we just did a training for Ukrainian therapists in Sarajevo. But Ukraine and Armenia also, we've trained Armenian therapists. They're stuck with laws from Russia that say that you cannot even do research with a Schedule I drug. It has to be approved as a medicine somewhere else. So again, FDA approval will open us up around the world to doing research in different countries. And the thing that will be so challenging is developing culturally appropriate treatment approaches, because we're going to be going to countries, we're trying to work in Rwanda, for example, where they have hardly any therapists or psychiatrists. So we're going to have to find local healers. How do we do that? Group sessions. And then also, I think when you look at populations that are refugees, they're refugees in families a lot of times. And so the whole family is traumatized at the same time. So I think we're going to not only need to do group therapy, but we're probably going to explore methods of treating families together, parents and their children together, with their communities. So I think the FDA will be a breakthrough around the world, but we'll have a lot of challenges really to globalize. Thank you. Great.
All right, so you guys were fantastic. Thank you so much.
Thank you.
Rick, it was an absolute honor to have you here. We'll let you go. He will be back for the panel later today. So thank you guys again for being an amazing crowd. And thanks, Rick Doblin.